Public Health and Safety Committee meeting for Monday, August 18th, 2025. The first item on our agenda is to approve the minutes of our previous meeting from 7/21 of 25, copies of which are in the packet. Did anyone note any adjustments they needed for the minutes? If not, I'll take a motion to approve the minutes as written.
I also make the motion.
Motion from Larson. Is there a second? Second from Watson. Further discussion? Seeing none, members in favor signify by saying aye.
Aye.
Aye. Opposed? None are opposed. That motion carries. Item number 2 is to consider approval or denial of various license applications. We have one recommended for denial this evening, which is Christopher Cron. And I believe we carried him over from last month, right? He had submitted evidence of rehab. Okay. And so, yep, I believe the chief, you have had time to review the evidence of rehab, and the memo that we got indicates that you are willing to change your recommendation to let Mr. Cron have a shot at this license.
That's correct.
Okay. So with that, with the chief having reversed his recommendation, if I think we can consider that one separately because it's recommended for denial. So at this point, if nobody has any questions about the other applications that appear in the packet, I will note, because we had a pending recommendation from the Liquor License Review Subcommittee to approve Class B beer and liquor license for the Wausau Museum of Contemporary Art and Ash Gardens. The subcommittee met prior to this meeting and recommended that we give both applicants a Class B beer and liquor license. Wausau Museum of Contemporary Art will have the full Class B. They were operating with beer and wine only. Ash Gardens actually was operating with a full Class B, but they were on a reserve license. And so they will be able to exchange their reserve for a standard license, and that will give us one additional reserve license available to award to new applicants, putting that total at 7. The Wausau Museum of Contemporary Art was a unanimous vote in the committee. The Ash Gardens passed with 1 no vote. So if there's no questions on that, I would take a motion to accept or deny various licenses as recommended by staff, with the exception of Christopher Cron. We'll consider him separately. We have a motion from Lukens. Is there a second? Second from Watson. Further discussion? Seeing none, members in favor signify by saying aye.
Aye.
Aye. Opposed? None are opposed. So that those licenses carry. And then on the previous denial recommendation for Christopher Cron, given the review of the rehabilitation evidence and the chief's recommendation, is there a motion to approve the license for Christopher Cron? Motion by Watson. Is there a second? Second from Lukens. Further discussion? Seeing none, members in favor signify by saying aye.
Aye.
Aye. Opposed? None are opposed. So that item also will go forward as a recommendation to approve. And that will give Mr. Cron a chance to hold that license. Item number 3 is an update on our community care paramedic program at Wausau Fire. And so we were very excited to launch this program. You have some of the slides in your meeting packet. But we have our community care paramedic is here tonight, along with Sean Carragher. So I guess if you guys want to come up and just walk us through a little bit like what your experience has been. Based on the materials that you have in the packet, it looks like it's been very successful. So welcome.
Thank you. Is this where I stand here?
You can, yep. And your mic is on, so you're good to go.
Very good.
Yep.
All right.
So, I guess I'll introduce the committee to you. Matt Kozlowski is our community care paramedic. So, welcome, and talk to us about what your experience has been out in the community.
Thank you. It's been nothing short of great. Very eye-opening as far as all the different community resources that we have. All the different trials and tribulations that our patients do still in this environment still face on a day-to-day basis to try to navigate their care and to not fall through the gaps of our healthcare system. We do have a very good and robust healthcare system in this area, but nevertheless, there are gaps that our patients do fall into, and we do see them on a daily basis on our ambulances. And my experience in the past being, we can move through the slides here. So I have 8 years of experience as a firefighter paramedic with the city of Wausau. Also a certified fire inspector and emergency medical instructor. How that helps is I can go into patients' homes and see the different kind of fire code violations, or not necessarily violations, but safety hazards in their homes from a different kind of perspective. And then being a medical instructor helps from the standpoint of being able to teach my patients about their disease process in a way that they can understand, and then actually take action to improve their lifestyle and their choices. Also a certified community care paramedic. So community paramedicine, if we move one slide forward, it utilizes expanded roles to enhance social determinants of health. And basically what I do is everything you see in the red box there. I help in those social determinants relating to how can we address the barriers that our patients are seeing in our community. And a lot of that is access to primary care. We see them on the ambulance because they're not getting their primary care from, per se, the traditional resources of a doctor or a clinic. And there's a lot of reasons for that. And that's where I feel like my program, or our program here, shines. Like a lot of other community paramedicine organizations across the state and the nation, is addressing those barriers and trying to bridge those gaps so that these patients stop falling down into the gap. So for access to primary care, sometimes it's as simple as transportation. They just don't have a means to get to their doctor. Their doctor is out of the area, or they can't have the mobility to be able to walk to a bus stop. So we look at, okay, can we get you, a walker or a cane or a scooter or medical transportation to meet you at your home? How can we cover that with insurance and other resources? If a patient has low medical literacy, they just don't understand their disease process. Like, I don't know what congestive heart failure means. I don't know what COPD is and how that affects me. Okay, let's talk about it. Let's teach you. And we can do that in an environment that's in their home, pretty low stress, low key. Doesn't really have to be, a high stress environment like the clinic or the hospital, where they're getting a lot of this education. And unfortunately, sometimes it's in one ear, out the other, because doctors are super busy. Their caseloads are huge. But I can sit with a patient for 2 hours and explain to them, okay, let's go through your fridge, let's go through your cabinets, and see how some of these dietary choices are impacting your health. So that's been a phenomenal experience. As far as home safety, every visit, especially the intake visits, include an inspection of the home if they so choose. So we look at things that are going to impact fall risk. Fall risk is huge in our community, as you looked through the earlier or the later slides. So how can we mitigate some of these things before they happen and try to get ahead of the curve, so to speak? Medications. There's a whole slide that I added earlier this morning. About 65% of the times that I look through a patient's medications with them, there are mistakes. And it's all manners of the spectrum. It's either mistakes from the pharmacy, from the clinic, from the patient level, or anywhere in between. They go to see an emergency room doctor, and then things get changed, and it's quite vast, all the different hands that can get involved with a patient's medications. So 65% of them have mistakes. And then connecting patients with community resources is kind of the bread and butter of how I affect change. I try my best not to duplicate resources. If there's someone in the community doing it, I need to shepherd that patient over to how can we get them involved. Whether that's Wausau Area Mobile Meals, ADRC, Meals on Wheels, AODA, District Attorney of Office of Election and Diversion, Three Bridges Recovery, Habitat for Humanity. They have a program coming to the community to address grab bars, as well as installing wheelchair ramps, Faith in Action, Adult Protective Services, Child Protective Services. The list goes on and on. So it's a great community to have this program to be able to kind of point patients in the right direction. I think where we differ and kind of shine as well is an out-of-the-hospital assessment and care. To be able to see a patient with congestive heart failure who's showing signs that they're starting to deteriorate, and being able to affect change and get on the horn with the primary care physician and get some orders in place and get this ship turned around so that we can get them back on their feet again before it snowballs into a situation where they need a 911 ambulance and an emergency room visit and potentially an admission, which could cost tens of thousands of dollars. If we can put the ounce of prevention in, it's worth that pound of cure. So what downstream effects that have, we'll go through some exciting slides coming up here. It reduces the need for emergency care in the form of 911 calls, hospital visits, and admissions, and improves the health and wellness of our Wausau residents. So how do we find our patients? We started off our program with a model that focused on patients with high frequent utilization of 911, and most often for issues that are most suitable for primary care providers. But we were seeing them on the ambulances and bringing them to the emergency room, get discharged a couple hours later, and then round and round we go with this revolving door. So we ran internal data on which patients call the most. We reviewed their medical history to determine if there are problems that the community care paramedicine can help with and resources in the community that we can steer them to. We also early on decided that patients who fell outside the parameter of high utilization, we should still take a look at those. And we're very happy that we did because we changed a lot of lives by doing that. These patients are deemed high risk as opposed to high utilizer. And basically what that means is even if they didn't call 911 frequently, if they have congestive heart failure, COPD, diabetes, asthma, fall risk, substance use disorder, all these high risk things that have great potential for serious complications down the road, we decided that they were the great patients to reach out to. We've got some examples of that coming up. Limited eligibility or access to traditional health care, those are our primary candidates as well. Low medical literacy where they need some education on their disease process. And we also most recently developed a referral process internally where our paramedics, when they go to someone's house for a 911 call, they can push a couple of buttons in their report and that patient information comes right to my desk, right to my secure email so that I can reach out to that patient if need be. We also open it up to ED staff, so in the emergency department, if they get there by means other than ambulances, which is a fair amount, they can make that referral as well, and then clinics in the area as well. So each visit consists of just a conversation with the patient is how it starts off, discussing goals, barriers, concerns, and current resources that they're currently using. We assess things like what does your daily activities of living look like and how independent are you during these. We go with a fall risk assessment, depression screening, nutritional screening, medication reconciliation, home safety assessment, and then a physical assessment along with vital signs. So, getting to the more exciting slides here. Next one, please. This is the enrollment data, and basically how well are we moving the needle. It's the slide where we look at once we have an enrollment date, once I actually sit down with a patient, we look 100 days or however many days it is. It could be 20, it could be 30, it could be 300. Before enrollment, and then the same apples to apples comparison after enrollment. So then we're getting a good ballpark of, okay, is this program worthwhile? Is it actually helping our patients to reduce their utilization of 911 and emergency department usage, along with other metrics? So this is what we found. In the first 8 months, we went from 129 calls to 911 down to 46, which is a 65% reduction in 911 calls for just this cohort of patients. I couldn't be happier about that result. I think there's a lot of room for growth there as well. There's a lot of ways we can improve, but so far, I think we're headed in the right direction. So what this means for us, if you look at the deeper meaning to it, other than just less call volume, is the average EMS call for us in our city takes about 1 hour, and that doesn't include the report writing. That's just time of dispatch, you're getting out the door, getting at the patient's house, getting them to the hospital, and then getting back in service. That's about 1 hour. So 1 hour times 83 EMS calls is 83 hours. You do the math on that, and divide it by 24, you have 3.45 full days where an ALS, advanced life support ambulance, is in service, ready to take a patient where they otherwise would have been tied up with somebody else. So I think that alone in 8 months speaks volumes for being able to provide that crew with time to train, time to get other things done around the station and see other patients. I actually just ran the numbers this morning. We're doing quite better than this slide indicates. We're up to 102 saved calls. So if you divide that out, it's 4.25 days after 9 months of actually being saved from calls. Next slide, talking just a little bit about the real bare bones preliminary cost. An ambulance transport to the hospital, Whether you're basic life support or advanced life support, you can see the numbers there, $1,400 versus $1,550. Or if you're on-scene care only, we did not transport the patient, $600 or $1,200, $600 or $1,200. So multiply that out, 83 calls. If all of them were transported, we're looking at just over $116,000 in savings. Not all of them were transported. So let's be conservative about it and say that, let's say half were transported, which I think it's a bit more than half. But that's still $82,000 and some change. So I think the realistic value is somewhere between those two, because we're not counting supplies or mileage either. So just bare bones, what could we potentially save with this program in 8 months? It's somewhere between those two figures. This is the first 3 months, first quarter of emergency department data. Not as significant, still heading in the right direction, a 22% reduction in emergency department visits at Aspirus Hospital, representing 12 fewer visits. So opportunities for improvement. I think that I'll take a lot of that on myself. Being on the ambulance for 8 years, I'm very good at knowing how to explain to patients when is and when is not a good opportunity to use an ambulance. But I'm not as well versed on how, when is a good time to go to the emergency room versus the urgent care clinic or your primary care doctor clinic, or when is it better to call your nurse triage line. So I sought some educational materials from Aspirus to be able to pass along to my patients and be able to better educate that, because they're not calling 911 and using an ambulance, but they're still getting to the ER via Uber and taxi and other things like that. So there's room for improvement. So fast forward to the next quarter, and that's the next slide, and we're looking at a 50% on the nose reduction in emergency department utilization. So we made significant improvements. I think there's still some to be made. Still a lot to learn from the system and how other systems have developed this, but at least we're making progress.
That is an amazing statistic. I don't know if anyone has had the experience or had a family member have the experience of needing to go to the emergency room, by ambulance or otherwise within the last couple of years. But there were some pretty long wait times because, even though, they have X number of staff and beds available, there were times that they were triaging folks and then, maybe having them wait out in the waiting room until that bed would open up. And sometimes that was dependent on a bed, if they were going to admit that person, opening up on the unit that that person needed to go to. So, if you're seeing that 52% reduction in, folks that maybe could have avoided needing
Absolutely.
to be in that space, that really could reduce that wait time that people are experiencing when they have that legitimate emergency, or I won't say legitimate emergency, but I guess more emergent emergency.
Right.
So that's huge.
Absolutely.
So
I couldn't agree more.
I can imagine our hospital really appreciates that.
Yeah, that statistic they absolutely loved, and I think they're going to like the next one as well. Next slide, please. So over the last 5 quarters, the average length of stay for my discharge patients, which is most of my high utilizer group, is spending about 3 hours before getting discharged. They're not usually getting admitted. There's some deviations there, but on average. So 3 hours multiplied by 52 visits is 156 hours saved, and that is almost a full calendar week of a hospital bed being open and available to take a patient where it otherwise would not have been. And that's just in 8 months worth of data. Actually, less than that. It's about 7 months worth of data. So I think these couple of slides are my absolute favorite to show what more can this system offer to be these downstream effects of just getting people the right care that they need. And it's 156 hours that some of my patients didn't have to sit in the emergency room and get care, that they were able to stay in their homes and be healthy and be comfortable there and not have to feel like they needed emergency department care. So I think that is another downstream effect that is just, it's hard to capture that. So real bare bones here, the average emergency department visit is more than 2,500, but I wanted to be conservative to not overstate the worth here and to be relatively conservative about it. So you take that times 52 visits, we're looking at $130,000 where my patients will never see that bill. And 85% or more of my patients right now report struggling financially. So that's $130,000 that they can not have to be under crippling debt. So add the two together, and we have 83 EMS hours plus 156 ED hours is about 10 days worth of time saved. Add the two together as far as cost goes, and you're looking at over the $212,000 worth of savings in 8 months. And I think that is, pretty conservative. There's no additional tests and laboratory work being done in the hospital. There's no mileage, there's no supplies. It's just bare bones, as low as it gets. There's a slide that I made here that unfortunately you're not going to be able to see. It's just a pie chart essentially, and it goes back to looking at the medication discrepancies. And if we have the time, I want to be respectful of everyone's time. I have some what amount to testimonials, just personal stories of what this actually looks like in practice. But I'll yield the time if we're kind of running on a budget.
We have a relatively short agenda tonight, so I think if you have something that you want to show us, I think it's important partly because we also live stream the meeting, so
Yeah.
the public can see the success of this program, and I would certainly hope that our media partners would pick up on your success as well.
Sure.
I think that that's something that really is, when we make some of these investments on the front end, sometimes it's hard to grasp their true value, but I think when we see results like this, knowing that it has real quality of life impact for our citizens, and it's the cost avoidance for them if they're having financial struggles is tremendous. So I would like to see whatever you'd like to offer us, because I think that it's important too, when we go out in the community and have conversations about programs like this, that people not only understand the need, but the value. It's important. So go ahead.
Sure, thank you. So this first one is a story of an elderly veteran living alone in an apartment. At my first visit with him, I learned that the day prior, he had a doctor's appointment where, among other things, they went through his medication list for accuracy and compliance. Medication reconciliation, where we sit down and go through everything that I find in the counter, everything that we find in the medicine cabinets in the bathroom. We pile it all up on the kitchen table, and one by one I go through the list to make sure that everything is where it should be. There's nothing extra, there's nothing missing. And 65% of the time we've found errors, some of which are significant. So we look directly at every pill, every bottle, to ensure accuracy. Out of the 23 of this gentleman's medications, we found 9 were wrong or missing. Most errors were medications that he didn't know that he was ordered to stop taking once he had gotten discharged from the hospital. Other errors were medications that on paper he was taking, but he didn't actually have in his possession. So at his doctor's visit, he said, yeah, I'm taking this. Everything looked good. But in practicality, being able to sit with this man at his kitchen table and go through everything, we found that it wasn't the case. He was also taking an extra blood thinner that the doctor knew nothing about. Neither the patient or the doctor had any idea that there was a single problem. That's the incredible advantage of the community paramedic program, is being able to spend time in the home. We can give that to our patients, and it's something that it's not fair to ask a doctor or a pharmacist to do, because it's not practical to have a pharmacist come to your home or a doctor come to your home and make visits these days. So that's something that we can offer. The same day, I was on the phone with his primary care doctor making a plan to get him back on track. He was also screened as high risk for nutritional screening and found that missing teeth were the biggest culprit. He was absolutely certain that he did not qualify for any dental care. He was done trying. He had spent hours on the phone before. So together we spent about 90 minutes on the phone between the VA, Medicaid, and other agencies, and we found him coverage. He's now set to receive full dental care and dentures that are 100% covered by insurance with no copay. We also worked with the landlord to install a smoke detector, CO detector, and shower grab bar. This patient called 10 times prior to enrollment and has not called 911 since I started seeing him. Another patient, the next ones are considerably shorter. We're often able to prevent true emergencies by stopping them in their early stages. Congestive heart failure patient who is stable in visit 1, well-managed CHF, minor issues. Second visit revealed that he had gained 5 pounds in about a week, and physical assessment revealed that he had some swelling in his feet, some new pedal edema. His doctor had recently adjusted his water pill, and he was now retaining fluid. If left untreated, the patient would likely experience pulmonary edema, which is filling of fluid in the lungs, and he would require 911 and emergency department visit and possibly a hospital admission costing him tens of thousands. I notified his primary care physician, who promptly ordered the adjustments in his medications, went right through me through the phone and right in his living room. and together we safely treated him at home without using 911 or the ED. This patient called 911 8 times prior to enrollment and once since enrollment. Another patient received a heart valve transplant who was unable to afford his medications. He couldn't afford his copay even after insurance reduced the cost. Together, we spent approximately 2 hours on the phone between his doctor's office, pharmacy, insurance company to try to understand why there was such a significant cost for his medications all of a sudden. We ended up finding out that the pharmacy never got a copy of his updated health insurance card and was charging the incorrect amount of over $100 extra. We updated the pharmacy and his copay dropped to zero. I picked up his medications within the hour and the patient was able to get back on track. This patient's 911 utilization has been cut in half. Another patient recently released from the hospital admission after treatment for aspiration pneumonia. Patient was prescribed an oral antibiotic and was told to continue taking it for 1 week. Patient was historically not very good at remembering to take prescribed medications for almost a year. Had no intention of going to pick up the antibiotic and was likely to result in a possible readmission to the hospital for pneumonia. With the patient's permission, I picked up the patient's antibiotics from the pharmacy and delivered them. Along with regular visits, I called this patient every morning and every night for 1 week, stayed on the phone with them until she took her antibiotic, and she successfully finished her course and was not readmitted for over 30 days. The remainder of the slides are mostly centered around fall risk. There's a good heavy chunk of them. So if you guys are interested in that, I'd gladly take questions or breeze through them, but that's about half the remaining slides, so I can.
That was an interesting read in our packet, so.
Okay, yeah, okay. We'll kind of kick through. So fall-related deaths by state, the CDC just released a report recently that Wisconsin is dead last in fall-related deaths and injuries. A lot of possible factors if you dig into the why. People point to icy winters, older than average population for the U.S., alcohol consumption, but a major source that they point to is more accurate reporting. We are just very good with our Wisconsin EMS system at reporting falls, and falls get reported quite accurately here as opposed to other states. But nevertheless, it definitely tells us that we need to take action and that we are missing the boat with our seniors and trying to protect the people from falls and fall-related deaths. As you can see, in Wisconsin, we, over the last several years, have experienced a 7.4% per year on average increase in falls and fall-related deaths. Most falls occur right inside everyone's private home. That is by far the number one source of falls is in someone's home. Makes sense, we spend most of our time there. Second only to nursing homes. Third is unreported, so there's a huge basket of it just didn't get reported. A public building, and then coming in fifth, the roadway. Getting more local. This is Wausau Fire Department statistics for 2024. We reported 693 transported falls by ambulance and 486 lifting assistance with no transport for a total of 1,179 total falls reported to 911 system through Wausau Fire. So if you run the math with 6,229 calls and then that number of falls, that amounts to almost 1 in every 5 times that our ambulances roll out of the garage, it's because of a fall. That's staggering. Even more staggering is one slide prior, or next actually, sorry. Falls by age. If you're 50 and over, that's 91% of our falls is folks ages 50 and over. And then most of our falls are happening at a standing level. So not necessarily up on the roof or up on a ladder. Most of them are happening right as you see me right now standing. So what are we doing as the community care paramedic program? Again, every single time I step foot in a person's home, whether that's the first visit or the 5th visit, I can assess the home for hazards and I can remedy them. That's one of the beauties of it. If it's just, hey, would you mind us remodel your living room a little bit and make this gap, between your wall that you walk through every single day so you can fit your walker in it? Would that be something smart so you don't have to leave the walker leave the safety and then use the wall and furniture? Yeah, I never thought of that. Okay, let's do it. And then by the time I leave the house, it's a safer place. Assessing the individual for fall risk and then making the appropriate resources aware of the problem, whether that's PT, OT, some kind of strength rebuilding. A lot of it is lack of exercise and just getting the person involved with access to physical fitness opportunities, as well as a huge one is nutrition. There's a lot of nutrition deficiency among my patients. I don't have the data here, but I have not once assessed a person for nutritional deficiency and they were in the low category. It's always moderate or high, and I would venture to say that most of it is high. So making a lot of referrals to ADRC to get the Meals on Wheels program involved, or Wausau Area Mobile Meals through Aspires Hospital involved, where people can get some access to good, well-balanced nutritional meals, get some of that muscle back so that the atrophy and the muscle loss stops and the weakness stops. They can avoid this negative trajectory of health and disability, where they can actually turn that around and be able to make some changes. We're also working with the Habitat for Humanity to install grab bars. That program is still ongoing. I don't believe it started up yet, but soon they'll be able to install a grab bar for qualifying people for $25, basically cover the parts cost. And then just patient education, whether that's body mechanics or just making some easy changes around the home that makes them safer. If we go on to the next slide here, just lighting up a hallway in the middle of the night when they're on the way to the bathroom, rubbing sleep out of their eyes. Being able to see what's on the floor in front of you is a huge way to reduce fall risk in the home. Next slide, with the grab bar program, we're really excited about that. This area specifically is in desperate need of people to install grab bars. The grab bars are there. You can get them at Menards for $12. It's just a matter of hiring a handy person to be able to come into your home and install them in a way that it's not going to rip out from the drywall and it's not going to cause a problem going forward. This area is kind of a desert for that kind of service. Services around the area, like local hardware stores that used to offer that program, stopped doing that. Not sure why, if it's liability or what the cause is, but we just don't have the service in our area. So the Habitat for Humanity program is going to be a game changer there. And then the next two slides are just things that I can do and often do on a daily visit with my patients. These aren't actual pictures, these are just things I got online, but it's very, very realistic from what I can do in an hour and a half with a patient while I'm talking to them about other medical issues. Let's get these walking paths cleared up so that we're not tripping and falling in the home. And then the last one, I just want to sum it up with a quote that I found that I think sums up our mission here. And that is from Archbishop Desmond Tutu out of South Africa. He fought heavily against apartheid. There comes to a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. I can remember my experience on the ambulance of just scratching my head at 3 in the morning after you've been to the same patient for the 4th time that night. There's got to be a better way to solve this problem. This person is suffering, and we're not able to help them by just transporting to the ER, discharged 3 hours later, and then we're back in this revolving cycle over and over again. This program, at least preliminarily, seems to be the answer to that problem. Not for everybody, but it's helping a tremendous amount of patients, and I'm here to tell you that it's worth pursuing, and it's been phenomenal.
Excellent. Anybody have questions? Carol has a couple. Go ahead.
Please.
I don't have questions. I just want to say again, publicly, thank you so much, because it's really admirable, you stepping up, to do this. And it's fascinating, all of this information. And it just, as I'm listening and looking at the slides, I'm thinking about all the people that you're helping and thinking, all of these people also have, whatever, they're either parents or, they have they have other people who love them. And so I thank you, because it's making a definite difference in this community. And it's really exciting to see this, to just see all the statistics. So thank you for that.
we couldn't do without your support at all. Like, this starts with you as well. So
Yeah.
thank you.
So excited to see our success. Years ago, we had tried just a tiny little pilot of community care paramedic, and we had just a flash of early success, but nothing sustainable that we could gather data from. So, so proud to see our program roll out now, and see you out there getting to know those patients, and really gain their trust and really find a way to keep them safe. And the ER is. It's not a fun place. It's kind of a scary place when you just don't know where else to go. And so I think to, be able to treat people in their home where they're comfortable and eliminate that visit for them, and that experience. I mean, to have half their day taken up by, an ER visit when they wouldn't have had to have, I think is huge for people. So I'm really glad to see that this is working. And Deputy Chief Plus has a comment. Go ahead.
I just want to also add that, Chief Kopp and I are extremely proud of the work that Matt has been doing. He's only been seeing patients for just roughly 8 months. And the impact he's made, the data is super impressive. The impact he's made with the community is very impressive. I know other organizations and other communities are taking a look at the progress Matt is making, and they're looking at how they can replicate the same program in their communities. So, job well done.
Thank you.
That's a program I'm excited that we have. So, I think as we have measured success with that, at some point, if we find that the need is such that we, are saving enough in terms of time and resources that we need to look at expansion, I think that's something that, down the line that we'd want to hear about. But I'm just glad that we have the results we have today to be able to present that data out to the community as well, and have people see. I think that originally when we started it, we knew there was going to be value, but I don't think that we figured it would be this kind of value in only 8 months. I mean, those are some big numbers. So thank you so much for your work out in the community. Anyone else have questions for Matt? If not, then we'll place his report on file. Thank you so much.
Thank you.
And our next item is discussion and possible action on proposal to adopt the most current edition of NFPA 1 Uniform Fire Code. And you have a memo in your packets from our Prevention Division Chief, Sean Carriger. He's here this evening. I guess, Sean, did you have things that you want to walk us through with the Uniform Fire Code and its adoption? I assume this will help you a lot in your inspections and things.
Yeah, so basically, what you guys have in your packet is kind of the, framework to update us from the 2012 up to the 2024. And in speaking with our fire prevention people at the state level, their plan is to move to the 2024 edition from 2012. Unfortunately, he said the state doesn't move real fast, so they're looking to accomplish that in 30 to 36 months.
Okay.
So we're hoping to get ahead of them and adopt the newest version, and when the next version comes out, 2027, then adopt that one as well.
Okay. Committee members, any questions on NFPA standard? I think it would make sense that we're up to the at least most current function of the fire code. I mean, I think that will help them in their inspection and enforcement efforts. So do we have a motion to move forward with adoption of the current code? Yes, go ahead. Go ahead.
Thanks, Chair. I just wanted to add also, in addition to having the most updated code, we recently had a recent ISO rating where they rate a department 1 through 5 on a series of different criteria. One of the areas where we actually lost points in this insurance safety office rating was the fact that we weren't utilizing the most up-to-date code. So this would help with our
So this
ISO
will
rating as
rectify
well.
that then. So, sure. Let's take a motion then to move to the most current version of NFPA.
I also make that motion.
Motion from Larson. Is there a second?
I'll second.
Second from Watson. Further discussion? Seeing none, members in favor signify by saying aye.
Aye.
Aye. Opposed? No one's opposed. We're good to go. Thank you so much.
Thank you very much.
Item number 5 is the tavern activities report for the month of July. Anything notable on the report that you wanted to walk us through, Chief? Looked like a fairly average month.
I'd say
as per usual, recently, it's a pretty quiet report. I think there were, I seem to have lost it here on my screen, but there were 2 bars that didn't have licensed bartenders on site, so they were assessed demerit points as well as shut down for the evening. But otherwise, it wasn't a very exciting bar report.
And it looked like that last assignment of points, at least until February, takes Hiawatha to 100. Is that correct?
I need to pull it up
Thought-
here.
I thought someone said that last citation brought them to 100 points. I mean, once we get to 100, then our procedure normally is to have a discussion with the owner.
I'm almost there.
Okay.
It's on page 40.
Okay.
Oh, I'm looking at the wrong thing.
Yep,
Sorry.
Hiawatha was assessed 50 demerit points for no licensed bartender on 7/5, bringing their total to 100 points, 50 of which were assessed in February and will remain until February of 2026. Often at that 100-point level, we summon the owner to the committee to have a discussion with us about, how they'll rectify that situation. If all of the violations in question are for no licensed bartender on premise, it's not real difficult to figure out what the problem is. I don't know if, rather than issue that, usually what goes out is a letter, formal expression of concern from the committee. The clerk sends that out. Typically, we ask the chief to meet with or talk with the owner and determine if there is a path forward for either to prevent additional points from accumulating or rectify the situation that's creating the problem. I guess, committee members, are you supportive of that effort taking place before we get too far down the road here? Go ahead, Sarah.
You mean follow the process?
Yeah.
Yeah.
The clerk would send out a formal expression of concern, which is a letter informing the license holder that they have accumulated 100 points. Typically, then we ask the chief to reach out to the license holder and just review the situation and see if they have a plan to eliminate future violations. It may have been a scheduling issue. It could be, maybe they need to have additional people licensed that aren't. I'm not sure what the problem is there, but is that something, chief, where you could reach out to the license holder and have that conversation? And, if it turns out that it's something where, we're not expecting rectification, then we could actually bring the owner in and have them meet with us. But, if it's something that,
Sure, I have no problem with that. In this particular case, it's a little cleaner and simpler. I find it hard to believe many of our local taverns don't understand that they have to have a licensed bartender on premises, and that's the totality of these 2 cases, which take them to 100 demerit points. But making sure that they understand that and they understand the potential consequences of additional violations would probably be the gist of my communication with them.
yeah, I think, and that really is all we need to start with. Sarah?
Being new to this committee, I was just curious where it escalates. So like 100 points, we typically send out letters and have a discussion, right? And then at like 150, or is it 200?
Well,
or I
the
don't know.
100 is normally when the owner is here. And, we then say to the owner, what is your plan to get things better? If there is no plan, then, we have tools. We can look at short-term suspension. We can look at, we have that discussion with the owner. If things continue to happen, then we have, an escalating system of tools from suspension all the way to revocation if the situation doesn't improve. And it really depends on what it is and what's happening. In many cases, when they get to 100, it's serious things. And, we are, at the end of the day, what we're looking for is improvement. We're looking for, in this case, they had 7 months between the 2 things. But at this point, if both of those violations were that the person in control of the premises didn't have a license, at some point they need to be made aware of, what that situation is, and that, anytime they're open, somebody in charge of the place has to have a bartender license. So they just can't be open with someone running the place that is not licensed properly. So, I think it's appropriate that, we would send them out that formal expression of concern. It's a letter that comes out from the clerk noting their points and their violations history, followed by some outreach from the chief. And, after that discussion, depending on the outcome of that, if it's his assessment of the situation that we maybe need to meet with the owner, then we certainly would do that. So,
Sure.
I'm okay with that.
okay.
I think just to make sure everyone understands what the law is, which is somebody can bartend in the city of Wausau without a bartender's license as long as the person in control, there is someone on premises that has a bartender's license and they kind of get to operate underneath that other individual's license. Historically, when we find establishments that don't have a licensed bartender, it's not because they're unaware of what the law is. It's through convenience or someone called in sick or whatever that case might be. But I would add that there are other long-standing establishments in this community where the owner of the bar calls to see what the status of a bartender's license is. And when I explain to him that it's not going to be available on that particular day, they said to me, oh, well, I'll cancel my plans and I'll just sit there so that I'm in the bar. Like, they understood the assignment and make the adjustments necessary to meet the criteria with us. So that's most of the time when we see that. It's not a lack of education or understanding. It's simply a case of lack of convenience for the owners of the
Well, and I think we've had others before that have told us that when they were faced with that situation where the license holder, whomever their license holder was to be for that evening, when they couldn't find someone to replace that person with, they were closed that night. They just didn't operate for that evening. I mean, that's a choice they can make as well. Obviously, it's not cheap, but it's an option to know that if they don't have someone, that they're just don't need to be open that evening. I mean, it doesn't happen all the time, but it has happened before. So, but yeah, if you could reach out and have that conversation, the clerk's office will send the letter, like they always do. And, then if you feel that we need to meet with the owner or have that conversation in a different manner, we certainly would do that. But
very well.
like to try to be amenable with it at first. So, so there's that. So if there's nothing else on that report that you guys have questions about, we'll place the rest of that report on file. Item number 6 is our community outreach update. So we'll invite Tracy Durante up to come and talk to us about her work. It looks like through her report, we've got a few more people housed, right? That had
Yes.
used shelter before. So
Correct.
welcome.
Thank you for having me. So yes, I don't have anything super significant in terms of numbers. Our shelter numbers were down just a little bit by a couple in July. We had about 31 new individuals access shelter. But yeah, I guess the highlight of the report really would be, again, we had a total of 5 males and 2 females that were in shelter, that were successfully housed and exited shelter. In addition to this report, I did forget to add 2 additional people that were not in shelter, but I did also help get housing in the month of July. And then the other highlight that I want to point out is just recently I conducted a survey. I created and conducted a survey with some of our shelter folks just to see what the interest of having mental health services brought into the shelter would look like. I had met with the Medical College of Wisconsin prior, and they were interested in doing that if the benefit would be there for our clients. And so after that survey, we did conclude that it would be beneficial for them to come into the shelter. And so we're in the beginning stages of talking through what that will look like and how often they'll be there. It may start out as maybe just once a month based on need, but I'm excited for that to kind of get up and running. And Matt's report is really tough to follow. He's doing a fantastic job. And so I'll be meeting with him in the next week or two to discuss how he can come into the shelter as well, whether it's once a week or once every other week. But we have plenty of clients in shelter with chronic medical issues that really could utilize some attention from Matt and his expertise, and hopefully reduce the number of ER visits from those folks as well.
Yeah, super helpful. I mean, that's really a success story as well. I mean, every month you have a few people that you get housing that then, that reduces their need for our emergency shelter. It looks like, according to your report, 2 also chose to enter sober living at Bridge Street Mission. So,
Correct.
I mean, if you add up all those numbers, that's a significant amount of help that people are getting. And I love the idea that mental health services may be available even sporadically at the shelter. I think our goal all along was to have that be a caring environment that is obviously for emergency use, but that when people are there, that there is a way for them to connect to something beyond that. And, whether that's through you or through your shelter staff, or whether it's through services that you bring in. I think that, this experience for all of us in terms of sheltering both the guests that need it and the people providing it, and the business community and church groups and volunteers who've been willing to donate their time and food and meals, everything. It's been such a positive experience. And not that it's something that we can do or afford to do forever, but I think we really, in terms of stepping up to fill that gap, we really have been able to help some folks. So very, very proud of those efforts. Sarah, you have a question for Tracy?
Yeah, I
Go
guess
ahead.
I have 2 maybe asks. So I liked how you included the volunteer hours. So 921 volunteers hours in the month of July. Is it possible to do a trend? Like just like, how you did with some of the, or maybe not those, but like maybe for month to month?
Sure.
Or would that maybe, because I think it would be cool to be able to see, like, are there times of the year where it slumps? Or, and is it volunteer hours like for donations and time, or just people?
Yep, so the hours that are reported are people who come to the shelter and actually provide volunteer services from 6 until 9 p.m., including meal preparation. So, yeah, if you want to see that number month over month, like graphed, I mean, that would
That'd
be.
be sort of cool.
Yeah.
I don't know, just
absolutely.
to see like where some holes might be and like who, yeah. So that would be awesome. And then I noticed you included other stuff from Catholic Charities at the end, or is that something else?
That's not me, sorry,
Oh.
that's not part of my report.
Okay.
I think
Um,
Gary's here.
Catholic Charities
Oh, you're
provides
here.
their own
Okay.
data, and Gary Veltis is here
Oh,
for that.
okay.
So
I didn't see that
Yep, so if
on
you have
there.
questions about their data, he's here for that. Otherwise, if you've absorbed their data that was provided,
I did, but I had one question. So I really liked some of the metrics that were on those reports, and we take that stuff from the users of our shelter, right? Okay.
Yeah.
So then someday we'll be able to sort of see some of those trends too of the people that we see.
I think the difference is I don't have a specific reporting system that I utilize. So with Catholic Charities and Salvation Army and some others, they are utilizing the HMIS system to put their data in and then abstract it back out. And I don't have access to that system. And so my reporting is done based on manual documentation, so.
And I think I probably asked you this question before, but that system, is it something you could, like, we could pay for your access to that would help, or, something to look for in the future as an expense?
Yeah, I mean, I think, I had tried to utilize that system in the past, and they do a desk monitoring, and so some of the metrics that they look for in their desk monitoring, like, we're not an agent, we're not a nonprofit, so we don't utilize the same stuff to report out, and so I wasn't meeting their metrics in terms of desk monitoring. And it's not to say that we can't figure that out. And for this, the shelter was a short-term kind of solution. So, do we invest all of that time in putting it in there, knowing that it's ending? And then is Bridge Street Mission going to be utilizing this system so we can continue? So I think there's a lot of different parts here. It would be beneficial, of course, but, I have talked to them about that, and so we're just kind of at a standstill with that right now. But we can certainly have further discussions on that
Okay.
moving forward.
Thanks.
And I also did want to let you guys know also that Bridge Street Mission is bringing in staff tonight to try to get some applications completed to enter into their program. And I have had a couple of meetings with Craig just to kind of start talking through, like, logistically how things are going to go and how we can align prior to them taking over.
I think I had heard that he was planning to put in some hours at our facility so that he could build a rapport both with the guests and the volunteers, so the transition was a smooth handoff there. And so I think that's helpful. It's possible many of our guests already know him, but I think that, just to make that a smooth transition, as they are working along with the preparation of their space and, they're working up to that handoff, I think it would be important, or at least helpful, every couple months if we could have just a snippet of an update for how that's going. Like, are they on track with their projects? Are we on track with our projects? Because I think the last thing we want to find is that, if their project is somehow delayed, that, the last thing we want to do is run out of time and money on our end to fill that gap. So, if we kind of could just get a little snapshot here and there of, how we're doing in relation to what we have the resources to carry through and how they're coming with their project, where those things are going to meet up. So it doesn't have to be, every month, but, as there's benchmarks to report, I would love to see those. So,
Madam Chair.
go ahead, Lou.
With all due respect, I think that Tracy's got enough to do on her hands right now, and if we need a report from Bridge Street Mission, perhaps we could get them in here to give us a report.
Well, and I don't know that it necessarily even needs to be formal. I think it's a question of, are they on track or not? And,
I'll take care of that.
Are we ready for that handoff? Because the chief has been networking with them, I think, a lot since we accepted their proposal, right? So,
Yeah, so that wouldn't be a Tracy project, that'd be a Matt project.
okay. If you're willing to take it on, it doesn't need to be every month, but, I think we're looking at, are we roughly maybe 4 to 6 months away from our planned handoff, right? So I think we just need to kind of keep track and make sure that we are on track if we're expecting that we're going to have, some type of minor delay or whatever it might be, just so that we can manage the expectations of both the council and the community. And I think the volunteers and the employees and the guests, just so everybody kind of knows what's happening, that we don't get close to the end of the line and then maybe have any surprises. That's all I'm looking to avoid. So,
Thank you, Chief.
You're welcome.
all right, yes, thank you for taking that on. Go ahead, Carol, yep.
Thank you. Tracy, I just wanted to also say, I noticed the volunteers too on here and really appreciated that, the volunteer hours. And then I think that's awesome, 921 volunteer hours. And then also the other assistance too, additional aid, transportation. I just wanted to read this so that if, for anyone watching, I know it's in the report and people can look at the packet, but medical, psychiatric appointments, bus passes, medication management, collaboration with St. Vincent de Paul, Catholic Charities, North Central Community Action, Social Services, Probation Parole, CW Solutions. Also just helping people obtain identification, additional services through ADRC. So there's a lot. That's a lot. And so, thank you. Collaboration with landlords and other nonprofits also. So I just don't know, like I would have had no idea, and even I don't without reading this. And so I just appreciate all the work that you do. And I also, with Matt having a community care, provider stop, like that's wonderful. So anyway, thank you. Thank you. Thank you all for all the work you've done with all of this, because it's huge.
It is amazing. It's been amazing since she started. We knew that we had a full plate for a more than full plate for one person. There's more than enough work to go around, but then we also then tasked her with the emergency shelter operations, and that has been a Herculean effort that they have handled with grace. So it's been, even just for our volunteer time there, we really enjoyed that evening and got to see things firsthand. And, for coming together quickly like it did, it's a great place. So go ahead.
Just wanted to add one other thing. And I know I already emailed you about it, but the volunteers that had reached out to me asking if they will be able to continue when it, switches to Bridge Street Mission, if that, I guess, whenever you're checking with the rest to I don't know what that process will be with,
Do you want me to address that?
Oh, you can if you want. Have you? Oh.
Sure,
I mean, I know you already did in your email, but if you want,
right.
just,
And so this is conversation with Craig Vincent. I find him to be a straight up individual. And I think the easiest, I think there were concerns about who's capable of volunteering there, and a litmus test for volunteering similar to volunteering at our shelter, which there isn't one. And so he gave the example of, I believe it was Sam's Club that produces a group of volunteers that come there right now to volunteer in their rehabilitation men's wing and serve meals, of which is a different group of volunteers every night. There's not a test that someone, or a application process to come in and work with their individuals in that capacity, which would be the same as in their shelter or in their day center. So I think the concerns that people shared with you about whether they would be able to continue to volunteer, I think what we're going to find, and what I expect, is that they're all encouraged to volunteer, and they're appreciated for volunteering, and they'll still have that opportunity to do that.
thank you. And then should I, like, I'm guessing just in the process though, or should they contact him? Or I'm just thinking like,
Yeah,
if I get back to them, is there anything I'm supposed to, or just,
I think it would be a bit premature to be contacting and be like, can we sign up to do that? We're still coming up with the construction plans, and I say we as in them. But I think what you can share with them is we're more than happy to have them volunteer now. Maybe they already are.
Yeah.
And I think Tracy's expectation and mine is that those individuals that have been volunteering for the shelter, that list of individuals to be contacted will still be very important in future shelters, and we'd be happy to share that list of individuals, because the reality is, as I forecast the future of serving the unhoused population in Wausau, the need for those volunteers and growing the number of volunteers, I anticipate to be larger before it gets smaller over a 3, 4, 5 year plan. So not only Bridge Street Mission and the Wausau Police Department, I'm certain, I don't want to speak for Catholic Charities, but you rely on volunteers to assist as well. And so it's not a case of, I think, any organization saying, these are my volunteers, we won't share that with you. We're just fortunate in this community to have individuals that will give of their time and talent to be able to help serve. So, you know what? You'll probably hear this again, but I kind of feel like we're all in this together, and now no one is successful without the other. So if Gary called up and said, hey, we need volunteers, here's what's going on, Tracy, can you give me 20 names and numbers? We would share those, and I think the other organizations in the community would do the same. So hopefully that puts some people at ease on their ability to continue to serve. We will create opportunities and find opportunities for them to continue to serve in that capacity.
I think
You're
that's
welcome.
fantastic, and I
Good
think
problem.
that we recognize that for all of our organizations that operate with volunteers, that having volunteers is a gift from the community, and so to have people that, like you said, are willing to give of their time, talents, whether they donate time, money, supplies, whether it's meals, whatever it might be, all of it is necessary, and we're so grateful to have all of it. So. I think as we move forward, if we just get those little updates here and there, just so that we know that we're on track for a smooth handoff. And I think the idea that you would, at least have the folks from the new facility start to spend time in our current facility, and so that the procedures and the policies are kind of the same, and that people that are utilizing the one service versus the other, get used to that. So I think that's helpful. In the meantime, right now. Our facility is doing a fantastic job for the service that it's there to serve. And they are never empty. There's always people that need them. So for all those that need it, it's there. I know just last month I encountered someone who really needed that service, and was able to get her connected with our facility. Found out that at least on an instance or two before that she had been able to access shelter and was accessing it again. So just helpful for us to, as we encounter people in the community that may not be aware of the shelter or where it is, or, that it's really a caring and welcoming place. I think that's important. So, great work. Does anyone else have questions for Tracy about any of it? If not, we'll place her report on file for this month as well. And that's our last item. We are out of agenda items, so I'll take a motion to adjourn.
Move to adjourn.
Motion from Watson. Is there a second?
Second.
Second from Larson. Members in favor signify by saying aye.
Aye.
Opposed? No one's opposed. We'll stand adjourned then. Thanks, everyone.